Hello students, today we are going to learn a very interesting topic, that is the median nerve. Median nerve is a mixed nerve, and if you see the origin, here is the brachial plexus showing the origin of the median nerve and other nerves too. And apart from origin, we will learn about its course and area of distribution. So the interesting fact about the median nerve, it is the main nerve of the anterior compartment of forearm, supplies the muscles of thenar eminence in hand. So it doesn't give any branches in the arm or in the neck or in the pectoral region. Directly it starts giving branches only in the forearm and also to the thumb muscles, which is called thenar eminence. It is also called as the laborer's nerve, as it supplies most of the muscles in the forearm which does coarse movements like digging the ground, lifting weight, etc. and are performed by all these coarse movements, they are all performed by the long flexors of forearms. It is also termed as eye of the hand or peripheral eye because it provides a sensory innervation to the pulp of the thumb, means the tip of the thumb, which is called pulp. So pulp of the thumb and the index fingers, which are used to see the signs and textures, you can feel certain things by closing your eyes, the texture of a cloth or how object is, all these you can feel because of the tips of your fingers, which are supplied by the median nerve, and also used for the performing fine movements like buttoning a coat, all these. So all these are the functions of the median nerve. So median nerve is otherwise called as laborer's nerve, and it is also called as eye of the hand because it supplies tips of the fingers. So let's see the root value of the median nerve. The median nerve arises from the brachial plexus. So we know the root value of brachial plexus is C5, C6, C7, here is the C8, and last is the T1. So the ventral rami of C5 to T1 gives rise to the brachial plexus, and if you see the origin of the median nerve, it is from the lateral cord as well as from the medial cord of brachial plexus. So among this is the lateral cord of brachial plexus, and what we are seeing here, this is the medial cord of brachial plexus. And you can see the lateral cord gives rise to lateral root and medial cord gives rise to medial root. So lateral root of median nerve and medial root of median nerve. So both these roots, they just join to form the median nerve. It is called median because it is present in the center axis of the arm. So all through the arm and forearm, it will be in the center, in the midline of the arm as well as forearm. That is the reason it is called as median nerve. So we know now the median nerve gets origin from the brachial plexus in the axilla by two roots, lateral root and medial root. The lateral root, we can see it is having the root value of C5, C6, and it gets a communicating branch from C7. So the lateral root value is C5, C6, C7. And don't forget to say ventral rami. So ventral rami of C5, C6, C7. And whereas the medial root, the root value is C8 and T1. C8, T1, which is from the medial cord of brachial plexus. So these two roots, so totally the root value is C5. We have to write both separately, C6, C7 for the lateral root of median, and medial root is C8, T1. So this is the root value of median nerve. Course, relations and distributions. So in the axilla, the median nerve lies on the lateral side of the third part of axillary artery. So I am zooming out to show you the axilla. So this is the median nerve, and we can see the two roots here, lateral root and medial root. We can see they are joining in front of the axillary artery, and further after joining the median nerve, it lies lateral to the third part. So it is lateral to the third part of the axillary. From anterior it goes to the lateral side, and then it enters the arm at the lower border of teres major. So till the lower border of teres major it is considered as axilla. Beyond the lower border of teres major is the arm. So in the arm, initially the median nerve lies lateral to the brachial artery. So we can see here this is lateral side and here is the medial side. This is the anterior view of whole upper limb. You can see that it lies lateral here. So in the arm, initially the median nerve lies lateral to the brachial artery. So we can see this is the axillary artery continues to form brachial artery. So it lies lateral to the brachial artery in the arm. I have put a direction to show it is lying lateral to the brachial artery, and then courses in front of the artery. We can see slowly it comes in front here. So here I am putting an arrow to show it comes front of the brachial, that is anterior to the brachial artery. And after crossing anterior, it lies to the medial. From lateral, it goes towards the medial side. So approximately it turns from lateral to medial at the site of insertion of coracobrachialis at the level of mid of the humerus. So almost in the mid of the humerus, it goes from lateral to the medial. So here we can see it lies purely medial to the brachial artery. After crossing, it runs to enter the cubital fossa. So at the level of insertion of coracobrachialis is the level where the median nerve changes its course from lateral to medial side, and finally it enters into the cubital fossa. So in the cubital fossa, the median nerve lies medial to the brachial artery. So it is medial to the brachial artery. So in this particular picture, bicipital aponeurosis is not there because it is removed. So here it is bicipital aponeurosis is removed, which separates it from the median cubital vein, which separates the median nerve from median cubital vein. And in the cubital fossa, it gives off some muscular branches from medial to lateral side to supply all the superficial flexors of forearm. So it supplies, it gives off, I am writing 1 to flexor carpi radialis. Then it supplies palmaris longus. Then it supplies flexor digitorum superficialis. This cut part is flexor digitorum superficialis. Pronator teres, as it pierces through the pronator teres, it also supplies teres, except flexor carpi ulnaris. So except flexor carpi ulnaris, rest all the muscles of the superficial muscles are supplied by the median nerve. Median nerve leaves the cubital fossa by passing between the two heads of pronator teres. At this point, it gives off anterior interosseous nerve, a thin branch which is called as anterior interosseous nerve, which is a branch of median nerve. Anterior interosseous nerve is purely motor and supplies 2.5 muscles. I will name them now. So it supplies flexor pollicis longus. So I will show you. You can see the muscle goes to this is flexor pollicis longus. We can see a nerve here supplying it. It supplies to flexor pollicis longus. So anterior interosseous nerve, it supplies flexor pollicis longus, which goes to the thumb. Then lateral half of the flexor digitorum profundus. This is flexor digitorum profundus. So lateral half, not complete. Flexor digitorum profundus, half of it. Then it also supplies pronator quadratus. This muscle what you are seeing is pronator quadratus. So it supplies. So these are the muscles which are supplied by anterior interosseous nerve, which is a purely motor nerve. And let's see the median nerve in the forearm. The median nerve passes downwards behind the tendinous arch, that is the bridge between the two heads of flexor digitorum superficialis. So here is this is the flexor digitorum superficialis, which we already marked, and we can see the nerve beneath it, that is the continuation of the median nerve, that is the actual continuation of the median nerve, which is passing downwards behind the tendinous arch. The arch is formed by flexor digitorum superficialis and it runs deep to flexor digitorum superficialis, about 5 centimeters proximal to the flexor retinaculum. So I will show you. This is flexor retinaculum. Flexor retinaculum is the modification of the deep fascia present in front of the wrist. So about 5 centimeters proximal means above to it. Proximal to the flexor retinaculum, the median nerve emerges from the lateral side of the flexor digitorum superficialis. So you can see it comes out from the lateral side of flexor digitorum superficialis, and then it becomes superficial, lying lateral to the tendon of flexor digitorum superficialis, and finally posterior to the tendon of palmaris longus. So this is palmaris longus. So we can see here, this is the posterior to the tendon. Here is the median nerve, posterior to the tendon of palmaris longus. In the mid-arm, the median nerve gives muscular branches to the radial head of flexor digitorum superficialis. So in the mid of the forearm, it gives a muscular branches to the radial head of flexor digitorum superficialis before entering into beneath the flexor retinaculum, that is called as carpal tunnel. So before entering beneath the carpal tunnel in front of the carpus, it gives off palmar cutaneous branch which passes superficial to the flexor retinaculum. Here it is not shown clearly, but it lies superficial to the flexor retinaculum, which is the palmar cutaneous branch. So it gives off palmar cutaneous branch which passes superficial to the flexor retinaculum to supply the skin over the thenar eminence, means in front of the thumb, this area. So it supplies the skin over the thenar eminence, and it also supplies the lateral part of the palm. The median nerve enters the palm by passing through the carpal tunnel, and where it lies deep to the flexor retinaculum and superficial to the tendons of flexor digitorum superficialis, flexor digitorum profundus and flexor pollicis longus. So superficial to these tendons, deep to the flexor retinaculum, we can see the median nerve here in this picture. This is the flexor retinaculum. So it lies beneath. The actual median nerve lies beneath. The other one is the cutaneous nerve which runs superficial to the flexor retinaculum. So it lies beneath the flexor retinaculum, superficial to the tendons of flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus. And it is associated with the ulnar and radial bursa which surrounds these muscles. And in the palm, the median nerve flattens at the distal end of the flexor retinaculum and divides into lateral and medial divisions. So you can see here, these are the lateral divisions and the other one are the medial division. Lateral and medial divisions. So the lateral divisions gives a recurrent branch which curls upwards to supply the thenar muscles. So you are seeing here, this is the recurrent branch which supply the thenar muscles, thumb muscles of the thumb. Then except the deep head of the flexor pollicis brevis, rest all the muscles are supplied by this recurrent branch. It then divides into 3 palmar digital branches, and the medial branch gives off 2 palmar digital branches. So you can see one branch is going to the thumb. This is 2 palmar digital branches. And the 5 palmar digital nerves supply the sensory innervation to the skin of the palmar aspect of lateral 3½ fingers. So we can remember as 3½ fingers from lateral side, which are supplied by the median nerve including the nail beds. On the dorsal side also it includes the nail bed, skin on the dorsal aspect of the distal phalanges, and it also supplies first and second lumbricals within the hand. So within the hand it supplies first and second lumbricals. So that is the nerve supply of the median nerve in the hand. Let's talk about the clinical aspect of the median nerve. Injuries of the median nerve, the lesions of the median nerve may occur at the elbow, in mid forearm, at the wrist and in the carpal tunnel. So starting with the elbow. So for injuries of the median nerve at the elbow, the median nerve can be injured due to application of the tight tourniquet during venipuncture. So we know that during intravenous injection or during doing any venipuncture to the median cubital vein, usually the clinicians apply the tourniquet above to the cubital fossa, so that the vein gets dilated and it is easily accessible. So if this application of tourniquet is quite tight, it may cause the compression of the median nerve at that side. That is one thing. And supracondylar fracture. This is maybe due to accidents. Supracondylar fracture of the humerus means this part of the humerus is fractured, so involving the median nerve injury also. Then entrapment of the median nerve between the two heads of pronator teres. So because of spastic or because of any tendinitis or any other lesions of the pronator teres, it may cause the entrapment of the median nerve between the two heads of pronator teres. And the nerve may also get entrapped under the fibrous arch which is formed by the two heads of flexor digitorum superficialis. So these are the reasons for the injury of the medial nerve at the elbow. Let's see the characteristic features in such cases. That is, the forearm is kept in supine position because loss of pronation. Pronator teres is affected here. So the hand will be supine. So it will be supine due to the paralysis of pronator teres. And wrist will be flexed and it is weak due to the paralysis of flexors of forearm, except the medial half of the flexor digitorum profundus and flexor carpi ulnaris. So because of that, what happens? There will be adduction. That is adduction of the wrist, because the flexor carpi radialis, which is an abductor of the wrist, is paralyzed. So there will be unopposed adduction due to flexor carpi ulnaris, and medial half of flexor digitorum profundus is active. So it will be adducted. So it will be supinated, partially flexed, adducted. So no flexion is possible at the interphalangeal joints. So interphalangeal joints, there won't be any flexion, and the possible of flexion is lost, and joints of the index and the middle fingers are affected. So this leads to a deformity which is called as benediction deformity. Benediction of hand, that means the patient tries to make a fist. So if he tries to make a fist, the index and the middle fingers remain straight. So if you keep index and the middle fingers, they remain straight due to the paralysis of both superficial and deep flexors of these fingers, leading to the loss of flexion at the proximal interphalangeal joints and distal interphalangeal joints. So because of that loss of flexion, these two fingers will be straight. So when you ask the patient to do a fist, so he won't be able to do. These two fingers will be straight. So it indicates the paralysis of flexor muscles, which means an injury of median nerve. The ring and the little fingers can be flexed due to intact nerve supply of medial half of by flexor digitorum profundus, which is supplied by ulnar nerve. The loss of flexion at the terminal phalanx of the thumb due to the paralysis of flexor pollicis longus. So flexor pollicis longus is also paralyzed. So this is called as benediction deformity. Next is the ape thumb deformity. So in this, the thenar eminence is flattened. The thumb is laterally rotated and adducted due to the paralysis of thenar eminence and normal adductor pollicis. So loss of sensation in the lateral half of the palm and lateral 3.5 digits, also due to the dorsal aspect of some digits, that is including the nail beds, nails of 3.5 digits is lost. The injury of this median nerve in the mid forearm, it results in the pointing of index finger. So index finger will be pointing due to the paralysis of radial head of flexor digitorum superficialis muscle. So the radial head of flexor digitorum superficialis is paralyzed, and that continues with the tendon of index finger. So that there will be a loss of flexion of the index finger, and other signs and symptoms will be same as the lesion of the distal part of the wrist, that is 𝐻𝐵 deformity, loss of sense of 3.5 fingers, all these will be the same. So which we are going to discuss again when we discuss along with the wrist. So next, injury of the median nerve at the wrist now, that is the distal part of forearm. At the wrist, the median nerve and its palmar cutaneous branch may be injured here. It lies proximal to the flexor retinaculum by deep lacerated wounds or cut or suicidal cuts. All these are the reasons of cutting the superficial cutaneous branches of the median nerve. So characteristic features at this level, there will be 𝐻𝐵 deformity due to the paralysis of the muscles of thenar eminence. We already knew that there will be 𝐻𝐵 deformity, and loss of sensation at lower lateral part of the palm. So lower lateral part of the palm, including the thenar eminence, there will be loss of sensations, and there will be loss of sensations for lateral 3.5 fingers. So 1, 2, 3 and half of this. So including the dorsal aspect of the nail beds, this part also included. So these are the characteristic features which we found in 𝐻𝐵 deformity or the compression of the median nerve distal to the forearm, that is just about to the flexor retinaculum. Next we shall talk about the carpal tunnel syndrome, which is more interesting here, and it is very important clinically because it often occurs at the carpal tunnel region. So here the injury of median nerve in the carpal tunnel is injured in the due to the compression of the median nerve. It produces a clinical condition called as carpal tunnel syndrome. So the carpal tunnel is formed by the anterior concavity of the carpus, means the carpal bones, they form a concavity and the flexor retinaculum bridges over it, and the tunnel is tightly packed with 9 long flexor tendons which goes to all fingers and thumb, and with their surrounding synovial sheaths, and along with it median nerve is also there. So the median nerve gets compressed in the tunnel due to its narrowing following a number of pathological conditions like tenosynovitis of flexor tendons. The reason may be idiopathic. So inflammation of the synovial membrane around the tendons, that is tenosynovitis, and bursa around the tendons may get inflamed, ulnar bursa, radial bursa, so bursitis may be there, and osteoarthritis of the wrist joint, and myxedema. Myxedema means it is deficiency in thyroxine hormone, so hypothyroidism results in myxedema in adults. So that also may be a reason of compression of median nerve, and retention of fluid in pregnancy, over fluid. So the fluid also may compress, and fracture causing the dislocation of lunate bone. So all these are the predisposing factors of carpal tunnel syndrome. The characteristics of carpal tunnel syndrome are feeling burning pain, pins and needles along the sensory distribution of the median nerve. So lateral 3.5 digits, especially at night, they will feel like burning, pricking, pins and needles. So that kind of sensation is felt along lateral 3.5 digits. And there is no sensory loss over the thenar eminence. So there will be no sensory loss because the cutaneous nerve is already given before the flexor retinaculum. Here only the median nerve is compressed, not the cutaneous nerve. So the thenar eminence, there won't be any sensory loss over the thenar eminence, and it is supplied by palmar cutaneous branch of the median nerve. So all these will be unaffected. Then weakness of the thenar muscles, because the thenar muscles are affected here, there will be weakness of thenar muscles and reduced conduction velocity of the median nerve. So if you do conduction velocity test of the median nerve, so there will be reduced conduction velocity where the velocity will be less than 30 meters per second if you do nerve conduction test which is a diagnostic test. And positive Tinel sign. What is this Tinel sign? It is positive with lightly percussion. If you do percussion at the midpoint of the flexor retinaculum over the nerve, elicits a tingling of pins and needles sensation. So this is called as Tinel sign. Percussing means just tapping. So this is percussing. Next, positive Fallon test. So let's see what about this Fallon's test. Fallon's test is performed by asking the subject to hold their wrist in complete and forced flexion. So we will be asking to hold their wrist in complete forced flexion and pushing the dorsal surface of both the hands like together like this for 30 to 60 seconds. We'll ask them to do. The test will be positive if the patient complains of burning and tingling or numb sensations over the thumb, index and middle and ring fingers. So if he complains this kind of senses, then it is Fallon's test is positive. So these are some of the important clinical correlations which are associated with the median nerve injuries. Okay, so I hope I made this topic simpler for you all to understand. Thank you.